In next few minutes, I will be showing you one of our study in which we tried to find out whether there are any OCT predictors of side branch restenosis in left main bifurcation angioplasty using decay crush technique. First, let me show you one case. So this was 60-year-old male. He came to us with the crescendo angina, normal LV function, angiography showed significant left main bifurcation disease with mid-LED CTO, RC was normal. This mid-LED CTO was tackled with the retrograde technique using reverse card technique, and this was the result after doing mid-LED CTO. As you can appreciate, in this view, the left main is critically diseased. It's a Medina class 111, and there is another lesion in OM. So we went ahead and we did OCT. We found that the lesion morphology is fibrotic, so we knew that it has to be tackled with the non-compliant balloon. And we went ahead and did this left main bifurcation angioplasty using decay crush technique. These are all the steps of decay crush technique. We first deployed the stent in the left LCX with protrusion in the left main, and then crushing of the first stent, followed by recrossing the side branch, first kissing, then placing a stent in the main branch, followed by pot, ostial flaring, recross, final kissing, and repot. So this was our final result. You all will agree with me that this was angiographically acceptable result. When we did OCT, we saw in LCX the stent was well opposed. There was no edge dissection. Expansion was good. Then we saw that in left main to LED run, we saw that stent was well expanded, well opposed, but there was stent studs hanging across the side branch ostium. So I must admit at that time in 2018, we missed this. We didn't have a 3D reconstruction at that time. This patient came to us after 9 months again with angina. Angiography showed that there is side branch restenosis. And when we did OCT and compared with the index OCT, we found that there was complete epithelialization of the stent studs that were hanging across the side branch ostium. So in this case, we did left main bifurcation using decay crush technique. We did final kissing balloon inflation, and this was the final pullback, and these were the stent studs that were hanging across the side branch, and this was the result after 9 months. So this led to our study that was OCT predictor of side branch restenosis in left main bifurcation angioplasty using decay crush technique. So this was single center retrospective study in which we enrolled 60 patients with complex left main bifurcation disease. Those underwent OCT guided left main bifurcation angioplasty using decay crush technique. We followed this patient for 1 year, and we did check angiography at the end of 1 year. Patients with angiographic evidence of side branch restenosis were identified, and their index OCT was compared between those with that of the patient who didn't develop a side branch restenosis. So this is an example of one case that came to us with the side branch restenosis, left main bifurcation disease, and patient underwent decay crush, angiographically good result, but patient came to us with side branch restenosis. When we studied its index OCT, we found that CTBP length, this is the final run. After final kissing balloon inflation, the CTBP length was 3.1, and we left new metallic carina of 2.6. In fact, we created 83% of iatrogenic stenosis, and this can be well appreciated in 3D reconstruction, in cross-sectional view, and even in the stent-only view. This is an example of another case who came back to us with the side branch restenosis. In this case also, the CTBP length was 2.3, but we left a new metallic carina of 1.7 after final kissing balloon inflation. And again, you can appreciate this in a 3D reconstruction, in the cross-sectional view, and even in the stent-only view. This is the example of a case who didn't come to us with the side branch restenosis. This is the pre-PCI, this is the post-PCI. And when we studied its index OCT, we found that there was hardly any new metallic carina. The side branch ostium was clear of any hanging stent studs, both on the 3D reconstruction as well as on the stent only view. And even in the cross-sectional view, it was clear figure of 8 or a Dumble sign that we have given it. So the results. So we had 60 cases, 12 patients came to us with side branch restenosis, and 48 patients didn't have side branch restenosis. When we compared the baseline characteristic, we found that SBR group had a statistically more syntax score, higher syntax score as compared to the NSBR group, and SBR group had a statistically significant more number of patients having syntax score of more than 32. When we compared the pre-PCI OCT, we found that side branch distal reference diameter was significantly lower in patient having side branch restenosis, and the side branch lesion length was longer, significantly longer in patient having side branch restenosis. When we compared the post-PCI OCT in both the groups, we found that side branch stent expansion, stent size was significantly lower in SBR group. Side branch stent expansion was again lower in SBR group, and there was SBR group had a more amount of iatrogenic side branch restenosis. And all the patients who developed side branch restenosis, they had hanging stent studs across side branch ostium. They had a more neometallic carina, and none of that patient had a clear figure of 8 or Dumble sign. So when we did multivariate regression analysis, we found that side branch distal reference diameter and side branch stent expansion were the independent predictor of side branch restenosis. When we did ROC curve analysis to find out the cutoff value, whether at which we can predict the side branch restenosis, we found that distal reference diameter of less than 2.8 had a sensitivity of 83% with a specificity of 62 predict side branch restenosis, and the OCT stent expansion of side branch less than 89% had a predictive value of around 80% to predict side branch restenosis. So when we are doing left main bifurcation using OCT, it's beyond MLD max. We have, during final pullback, we have to achieve almost nil hanging stent studs across side branch ostium. We have to achieve clear figure of 8 near native carina, and we should have almost minimal neometallic carina. So what went wrong in these cases? I think when we analyze our cases, we thought that either we may have not used appropriately sized side branch ostial balloon. The size was not appropriately sized, number one. Number two, we may have missed alternate high pressure balloon dilatation. And third, we think that we went too proximally secondary cross, and that may be the reason for having all these stent studs leading to side branch restenosis. This is a graphical presentation that has been made by our research group. So after seeing all this, we thought that one should go for proximal side branch optimization before crushing the first stent. Always go for a second step crush, because whenever you crush the side branch stent, we always take a balloon as per the distal reference diameter, and we always end up having malopposed stent studs at the left main. So step crush is essential. And once you do the crushing of the side branch stent, there is always a risk of deviation of stent studs from carina. So that is why the first recross should be proximal. But before first recross, the step crush is very important. Because if you have not done step crush and we are trying to go proximally, we may go abluminally, again leading to a large amount of stent studs across side branch, followed by, to oppose these stent studs that has been deviated from carina, the second PSO is required, followed by first kissing, main branch stent placement, followed by first spot by keeping the marker of balloon at carina. Now this second recross should be distal to have minimal neometallic carina, minimal stent studs across side branch ostium, followed by second kiss, and this second kiss should always be followed by, it should be followed by alternate high pressure balloon dilatation, followed by second pot and final result. So left main bifurcation angioplasty using decay crush, it's beyond MLD max. We have to use double kissing, double crush, double PSO, double pot to have minimal stent studs across side branch with first proximal and second distal recross. And this use of OCT in bifurcation angioplasty, we have published in a review article in Frontiers in Cardiovascular Medicine. Thank you very much.